Good afternoon. My name is Susan Wherley, and I'm a third-year resident at UH. I'm going to present our research about the use of the National Surgery Quality Improvement Program, or NSQIP's surgical risk calculator, in patients undergoing pelvic organ prolapse repair. I have no disclosures. Pelvic organ prolapse is a prevalent and growing concern. An estimated 13% of women will have surgery for prolapse in their lifetime, with over 300,000 surgeries performed each year in the United States. This is likely to continue to increase with growing awareness and as the baby boomers age. Postoperative complications are relatively common, affecting up to 1/3 of patients in some studies. The NSQIP risk calculator was developed by the American College of Surgeons to more accurately predict which patients may experience a complication after surgery. This is the risk calculator. You can enter any given procedure by CPT code, as well as 19 preoperative patient characteristics, such as ASA class, functional status, and comorbidities like diabetes and hypertension. The calculator then reports a percentage risk of a postoperative complication occurring. This is broken down into risk of any complication, a serious complication, and specific complications including pneumonia, venous thromboembolism, return to the OR, and death. The objective of our study was to externally validate the ability of the risk calculator to predict postoperative outcomes in patients undergoing major pelvic organ prolapse repair. This was a retrospective review of 354 patients undergoing major prolapse surgery at our academic medical center. Calculated risk scores were compared to observed complications, and the risk calculator's predictive ability was assessed with C-statistics and Breyer scores. The primary outcome measure was the ability of the calculator to predict any complication. As you can see, most of our patients were younger than 75 and overweight or obese. Almost half were ASA class 3 or 4 and had hypertension requiring treatment. Rare comorbidities included smoking, diabetes, and dyspnea. Other comorbidities were rarer still. These are the qualifying major prolapse procedures. The majority of our patients had either a laparoscopic colpopexy or a uterosacral ligament suspension. Most surgeries included concurrent procedures, such as hysterectomy, AP repair, perineorrhaphy, or sling placement. In many cases, the primary prolapse procedure carried a lower predicted risk than one of the concomitant procedures. We recorded the predicted risk for both the primary prolapse procedure as well as the procedure conferring the highest level of risk if they differed. These are all of the complications included in the risk calculator's predictive modeling in decreasing order of prevalence in our study. For example, as you can see in the top row, the predicted risk of any complication was 6.2% or 7.7%, depending on the CPT code used, but the actual complication rate was 28.2%. The risk calculator underpredicted complication risk in general, as well as the risk of the most common postoperative complications, which were urinary tract infection and superficial surgical site infection. To evaluate the predictive ability of the risk calculator, we calculated C-statistics and Breyer scores. The C-statistic, also known as the area under the curve of a receiver operating characteristic curve, determines the predictive strength of a model. A value of 0.5 is no better than chance, while 1.0 is perfect predictive ability. Models are typically considered reasonable when the C-statistic is higher than 0.7. The Breyer score is the mean squared difference between the predicted risk and the actual outcome. The lower the value, the better the predictive ability. So if a model perfectly predicts the outcome, the Breyer score would be 0. As you can see in the red box, For our primary outcome of the occurrence of any complication, C statistics were 0.54 and 0.52 for the primary prolapse procedure and the highest risk procedure, respectively. Breyer scores were 0.25 and 0.24. Similarly poor predictive ability was observed for our secondary outcomes, including serious complications, surgical site infections, and UTI. This figure shows the ROC curve for the calculator's ability to predict the occurrence of any complication. As you can see, the curve displays a predictive ability that is not significantly better than chance, with a C statistic value of 0.529. Therefore, we concluded that the NSQIP surgical risk calculator displayed poor predictive ability in our cohort of patients undergoing prolapse repair. Strengths of this study include the diverse surgical population, both in regard to patient demographics and surgical procedures performed. Weaknesses include the retrospective design, the impact of individual practice patterns on the results, and the fact that our statistical models have limited utility in evaluating low-frequency outcomes, which include most postoperative complications with the exception of UTI and surgical site infection. Being able to accurately estimate postoperative risk enhances a physician's ability to obtain informed consent, a critical aspect of preoperative counseling. Given the limited utility of the NSQIP risk calculator in this population, better predictive models are needed for patients undergoing prolapse repair. Acknowledging the limitations of this calculator should encourage continued work toward the development and validation of more accurate predictive models in this surgical population. In imagining a calculator that would be of greater use to female pelvic surgeons, the use of specialty-specific risk factors, such as history of UTI, prolapse severity, concurrent incontinence, or prior surgery, as well as elderly-specific conditions such as frailty, should be considered. Improving the process of patient selection and informed consent in surgical management of pelvic organ prolapse remains of critical importance as we strive for optimal outcomes. Thank you for your time.